Welcome. Today we're diving into a condition called drug-induced pleuritis. This occurs when certain medications trigger inflammation of the pleura, the lining surrounding your lungs. Let's explore its causes, symptoms, and management. So, what causes drug-induced pleuritis? A variety of medications have been implicated. Some common culprits include drugs used to treat autoimmune diseases like lupus, medications for cardiovascular conditions, and even certain antibiotics. Amiodarone, methotrexate, hydralazine, procainamide, and nitrofurantoin are some well-known examples, but this isn't an exhaustive list. Essentially, any drug that can trigger an inflammatory or hypersensitivity reaction in the body has the potential to affect the pleura. Now, let's look at the pathophysiology. The exact mechanisms are still being studied, but it's believed that drug-induced pleuritis often involves an immune-mediated response. The drug, or its metabolites, may act as haptens, binding to proteins and triggering the immune system. This immune response leads to inflammation of the pleural membranes. This inflammation can cause fluid to accumulate in the pleural space, leading to pleural effusion, and also thickening of the pleura itself. Regarding epidemiology, pinpointing the exact incidence of drug-induced pleuritis is challenging. It's often underdiagnosed or misdiagnosed as other causes of pleurisy. The occurrence largely depends on the prevalence of the specific drugs associated with the condition and the individual susceptibility of patients taking those drugs. It's something clinicians should be aware of, particularly in patients presenting with pleuritic chest pain who are also on multiple medications. What are the signs and symptoms? The most common symptom is sharp, stabbing chest pain that worsens with breathing or coughing. This is known as pleuritic chest pain. Other symptoms may include shortness of breath, a dry cough fever, and sometimes general fatigue. If a pleural effusion develops, you might also notice reduced breath sounds on the affected side. The severity of symptoms can vary significantly from person to person. How is drug-induced pleuritis diagnosed? The diagnosis typically involves a combination of factors. Firstly, a thorough medical history, including a detailed medication review, is crucial. Imaging studies, such as a chest X-ray or CT scan, can help visualize the pleural space and identify any pleural effusion or thickening. A pleural fluid analysis, obtained through thoracentesis, a procedure to drain fluid from the pleural space, can help rule out other causes of pleurisy, such as infection or malignancy. Ruling out other causes is key, especially if the patient is not on a known offending medication. This can include blood tests to check for autoimmune diseases and infectious markers. Drug-induced pleuritis doesn't typically have a formal classification system like some other diseases. However, it can be characterized by the type of pleural effusion, for example, transudative or exudative, or by the underlying immunological mechanism suspected. Also, its severity can be graded from mild, self-limiting to severe with significant pulmonary function impairment. The cornerstone of treatment is discontinuing the offending medication. In many cases, this is sufficient to resolve the pleuritis. Pain management is also crucial, often achieved with NSAIDs or other analgesics. If the symptoms are severe or if a large pleural effusion is present, corticosteroids may be prescribed to reduce inflammation. In rare cases, thoracentesis may be necessary to drain the pleural fluid and relieve breathing difficulties. Monitoring the patient closely after stopping the drug is essential to ensure symptom resolution and prevent recurrence. Prevention primarily involves careful consideration of medication choices, especially in patients with a history of drug sensitivities or autoimmune conditions. Clinicians should weigh the risks and benefits of each medication and monitor patients closely for any signs or symptoms of pleuritis, particularly when starting a new drug known to be associated with this condition. Education of the patient about the potential side effects of their medications is also vital. The prognosis for drug-induced pleuritis is generally good once the offending medication is stopped. Symptoms often improve within days to weeks. However, in some cases, the pleuritis may persist or recur, even after stopping the medication. Recent research is focusing on identifying biomarkers that can help predict which patients are at higher risk of developing drug-induced pleuritis and on understanding the specific immunological mechanisms involved. This will hopefully lead to more targeted therapies and improved patient outcomes in the future.